আজকে ক্লাস তোমাদের ব্রঙ্কিয়াল অ্যাসমা and COPD উপরে রয়েছে। হ্যাঁ, the topics which will be covered today will be on bronchial asthma. The next day we will be taking up treatment of bronchial asthma, COPD and the cough. So what is bronchial asthma? Anyone knows? What do we mean by bronchial asthma? There are two terms, bronchial asthma and chronic obstructive pulmonary disease, COPD. Basically, a patient when develops breathlessness due to bronchoconstriction, intermittent attacks or persistent attacks, then we say either the patient is suffering from bronchial asthma or COPD. Generally, the difference is the reversibility. In bronchial asthma, the patient suffers from reversible episodes of bronchospasm. Inflammation is the main culprit here. While in COPD, there is basically irreversible episodes of bronchospasm, that inflammation plays a role here, but reversibility is not seen. Here, COPD patients, they show more parasympathetic tone, and anticholinergic have a great beneficial effect in patients of COPD. Inflammatory disease, in which the patient suffers from reversible episodes of airway obstruction due to bronchial hyperresponsiveness. Although chronic inflammation can lead to irreversible airway obstruction later. So, in advanced bronchial asthma, even these reversible episodes may turn out to be irreversible. In early phase, smooth muscle spasm, number one thing. Number two thing is excessive secretion of mucus that may clog the bronchi and the bronchioles, worsening the attack. So, two pathophysiology are there. Number one thing is smooth muscle spasm, and number two, excessive secretion of mucus. In late phase, inflammation continues, accompanied by fibrosis, edema and necrosis of bronchial epithelial cells. So, irreversibility will be seen in the later phase. Cardinal symptoms, patient may present with breathlessness, severe breathlessness, wheezing. And what do we mean by wheezing? Wheezing is a musical sound that comes out during respiration. You can hear it by ear. Cough and chest tightness with worsening of these symptoms at night. It's a cardinal feature of bronchial asthma that the exacerbation are most of the exacerbations are seen at night. Now, when we come to pulmonary function test parameters in bronchial asthma patient, peak expiratory flow rate, forced expiratory volume in the first second, and the mid maximal expiratory flow rate are all decreased in asthma. Obstruction is the main feature, airway obstruction. So, all these parameters are decreased. FEV1, forced expiratory volume in the first second, is considered as the gold standard. Arterial oxygen saturation is reduced in early phase of acute attack. যখন প্রথম early phase এর ক্ষেত্রে we get hypoxia, but the carbon dioxide level in the blood in the arteries are decreased. Why? Because of hyperventilation. But in advanced cases of bronchial asthma, we get hypercarbia. The carbon dioxide level start to increase because of respiratory depression. So, but as obstruction increases, PaO2 reduces while PaCO2 increase. কেন এটা হতে হয়? কেন এটা হয়? Because of respiratory muscle fatigue. Types of bronchial asthma. Bronchial asthma can be divided into two broad types. One is extrinsic asthma, which is more common, and the other is intrinsic asthma. Extrinsic asthma can be again atopic extrinsic asthma and non-atopic extrinsic asthma. So, what is extrinsic asthma? They are associated with specific allergen pollen or house dust mite. They are mostly episodic, that they are not persistent, they are episodic, and they are less prone to status asthmaticus. What do we mean by status asthmaticus? It's the serious life-threatening attack of bronchial asthma. Okay, it's a medical emergency condition that requires hospitalization. So they are less prone to status asthmaticus, and again they may be atopic or non-atopic. What do we mean by atopic asthma? They are basically allergen induced. Here IgE, immunoglobulin E level will rise. So they are seen in majority of the patients. Sensitization with specific vaccine may help such group of patients. Now non-atopic extrinsic asthma, there is a precipitating factor like that of atopic asthma, but that the pathological basis is not allergy. So asthma attack may be stimulated by some non-specific stimulus like exercise, common cold, okay, exercise, cold, such as chemical irritants. Now coming to intrinsic asthma, there is no immunological basis, no precipitating factor for the asthmatic attack. It is perennial, around the year it is seen, and is more prone to develop status asthmaticus. Okay. Coming to status asthmaticus, is the severe acute life-threatening attack of bronchial asthma. Cardinal features are, due to severe breathlessness, the person becomes fatigued. So exhaustion may be seen, the person becomes cyanosed, the person may have tachycardia, and in the extreme advanced case, the person may develop bradycardia, which shows the person may collapse anytime. Hypotension may be seen due to persistent hyperventilation, fluid loss occurs, the person suffers from dehydration. There may be metabolic alkalosis due to hyperventilation. Cardiac asthma, bronchospasm precipitated by uncompensated congestive heart failure. Now coming to pathogenesis of the bronchial asthma. Now what happens when a specific allergen is exposed to the human being suffering from bronchial asthma? So they bind to the receptor, IgE receptor on the mast cells. What happens? The other inflammatory cells are recruited. There is degranulation of mast cells and release of chemical mediators from the other cells even. Now there are chemical mediators released immediately, which are already stored in the inflammatory cells, like histamine, like basically proteolytic enzymes, like TNF alpha. This occurs in seconds, and then again there is synthesis of mediators from the membrane phospholipids like leukotrienes, like TNF alpha, and then lastly there is finally with time, over time, there are activation of genes that lead to synthesis of mediators that include leukotrienes, cytokines and others. So chemical mediators like histamine, leukotriene C4, LTD4, LTB4, cytokines, adenosine, prostaglandins, platelet activating factor, eosinophilic cationic proteins and neuropeptides. These are the mediators released. Histamine does not play a major role in pathogenesis of the bronchial asthma. So antihistaminics have got lesser role in patients of bronchial asthma, and leukotrienes, they play a major role here. Now after the mediators are released, they cause inflammation, mucosal edema, bronchial hyperreactivity leading to bronchospasm, mucus secretion, and in the long run epithelial damage. Now what happens? This is a bronchial smooth muscle cell, is basically there we have muscarinic receptors like M3 receptor and the sympathetic receptors, that is beta 2 receptor. Now beta 2 receptor, on stimulation they are stimulating adenylyl cyclase because they are GH protein coupled receptor. They increase the production of cyclic AMP and that is resulting in the decrease in bronchial tone leading to bronchodilation. So, stimulation of beta 2 receptor that causes bronchodilation. Now again there is M3 receptor which stimulation causes increase in cyclic GMP. So what happens? Beta 2 receptor is there, stimulation of which causes bronchodilation. So B2 agonist, they find a place in the quick relief for the patients of bronchial asthma. Again M3 antagonist, rather to say anticholinergics, they are also used as a treatment for patients of bronchial asthma by antagonizing M3 receptor. Again I will show in the figure where are the different class of drugs acting in patients of bronchial asthma. So beta 2 agonists like salbutamol, they help in bronchodilation and find a place in a therapy of bronchial asthma. M3 antagonists like ipratropium, tiotropium, they find a place in the treatment of bronchial asthma. Again methylxanthines like theophylline, these are phosphodiesterase inhibitors, they inhibit the breakdown of the cyclic AMP and thus they are helpful in bronchodilation. Again leukotriene receptor antagonists, they help in bronchodilation. Again IgE antibody is a monoclonal antibody omalizumab, they inhibit the interaction of IgE with the receptor and thus they are helpful in allergen induced severe bronchial asthma. Again sodium chromoglycate, they inhibit the degranulation of the mast cell. So histamine is not an important mediator of human asthma and therefore antihistaminics are not used for the treatment of bronchial asthma, while leukotrienes and IL-4, interleukin 4, they are important mediators of acute asthma and thus leukotrienes antagonists are useful. Now coming to the drugs used for bronchial asthma. Number one is selective B2 agonist, beta 2 agonist. These are the mainstay of therapy for symptomatic quick treatment that include short acting beta 2 agonist and the long acting beta 2 agonist. Short acting beta 2 agonists, they include salbutamol, terbutaline. These are most commonly clinically used. Again levosalbutamol or levalbuterol. Long acting beta 2 agonists, they include salmeterol, formoterol, vilanterol, indacaterol and others. Non-selective sympathomimetics, non-selective means they are effective against beta 2 and other adrenergic receptors. So like epinephrine, ephedrine, isoprenaline and oxyprenaline. Coming to anticholinergics or antimuscarinic, they include short acting muscarinic antagonists like ipratropium, oxytropium, and long acting muscarinic antagonist, they include tiotropium, glycopyrronium, aclidinium and umeclidinium. Methylxanthines, they include theophylline, aminophylline, doxophylline, diprophylline and choline theophyllinate. Corticosteroids that can be used orally, parenterally and via inhalation route. Oral they include prednisolone, prednisone, methylprednisolone, dexamethasone and betamethasone. Parenteral hydrocortisone and methylprednisolone may be used. Inhalational is the most commonly used preferred route of administration. It includes beclomethasone, fluticasone, budesonide, flunisolide, cyclosonide and others. Mast cell stabilizers that include sodium chromoglycate, nedocromyl ketotifen. Leukotriene modulators that include 5-lipoxygenase inhibitor, that is xylitol, and leukotriene receptor antagonists that include jafilucast, montelukast. Monoclonal IgE antibodies that include omalizumab and miscellaneous are benralizumab, tezepelumab and others. So acute attack of asthma is reversible by using bronchodilator. However, underlying pathological changes continue mainly in adults. So preventing asthmatic attack is beneficial in preventing gradual damage to alveoli. So inhalational corticosteroid is a drug of choice in bronchial asthma to prevent the asthmatic attack. Now coming to sympathomimetics. Beta 2 receptor stimulation, we have seen that causes increased cyclic AMP production in the bronchial smooth muscle that leads to bronchodilation. Also increased CAMP in the mast cells and other inflammatory cells which possess beta 2 receptor that causes decrease in the mediator release. So two mechanisms of action. There are four mechanisms, we will come later on. Adrenergic drugs are the mainstay of treatment of reversible airway obstruction, but should be used cautiously in hypertensives, ischemic heart disease, and in those receiving digitalis. Hypertensive ischemic heart disease is because they are not completely acting on beta 2. Some they also act on beta 1, leading to tachycardia. So that would be detrimental in patients of hypertension and ischemic heart disease. And again, these beta 2 agonists, they causes hypokalemia. So we should be cautious while using the digitalis. The beta 2 agonists are the most effective and fastest acting bronchodilator when inhaled. Now coming to non-selective sympathomimetics like epinephrine, ephedrine. Because of their non-selective action leading to cardiac stimulation like tachycardia, hypertension, worsening of angina and arrhythmia, they are not commonly used. Their use has declined with the advent of beta 2 agonist basically. Epinephrine and isoprenaline were used initially by inhalation when beta 2 agonists were not there. Epinephrine is sometimes used subcutaneously to treat patients of status asthmaticus because besides bronchodilation, it also reduces pulmonary edema. Metoprolol or oxytocin is a longer active derivative of the isoprenaline with more specific action on the beta 2 receptor. Incidence and severity of side effects are less prone to isoprenaline. Ephedrine is a longer acting but slow onset CNS action has declined its use. So coming to selective beta 2 agonist is the mainstay of therapy in patients of bronchial asthma as a bronchodilator. It can be short acting, it can be long acting. It acts by, there are four mechanisms of action. Very important one is causes bronchodilation by increasing cyclic AMP in the bronchial smooth muscle. Is the number one and the most common, most important. Second is it inhibits the release of bronchoconstricting inflammatory mediators from the inflammatory cells like mast cells, and then mast cells, basophils, eosinophils, neutrophils and lymphocytes. They inhibit microvascular leakage and they increase the mucociliary transport by increasing the mucociliary movement. Selective beta 2 agonists, beta 2 receptors on the inflammatory cells desensitize quickly. So on persistent use of beta 2 agonist, the beta 2 receptor become desensitized on the inflammatory cells. So their action of decrease in inflammatory release, inflammatory mediator release will gradually decline with persistent use of beta 2 agonist. But this action, this desensitizing action is not seen with bronchial smooth muscle. So bronchodilator effect is maintained even on prolonged use. Faster onset of action, we are going with short acting beta 2 agonist like salbutamol, like terbutaline. So is the faster onset of action most effective in reversing bronchoconstriction and therefore preferred in the symptomatic relief of acute attack of asthma. Both salbutamol and terbutaline are most commonly used. Coming to salbutamol, it has got highest beta 2 selectivity among the short acting beta 2 agonist. It further increases by inhalation route. By inhalation route, onset of action is 5 minutes and action persists for 3 to 6 hours. Oral bioavailability is 50%, duration of action 4 to 8 hours by oral route. They are not suitable for prophylaxis. For prophylaxis, long-acting beta-2 agonists are preferred. So they are not suitable for prophylaxis. Side effects are tremors, palpitation, hypokalemia and restlessness. These are more commonly seen on oral and intravenous route, not with the inhalation route. Terbutaline, similar in action in properties like that of salbutamol, it is perhaps the only bronchodilator that can be used in pregnancy, that can be safely used in pregnancy. Coming to long-acting beta-2 agonists that include formoterol, salmeterol. These are highly lipid soluble, so longer acting, half-life much longer, 6 to 12 hours than short-acting beta-2 agonist. Onset of action slow, except for formoterol. Formoterol have got quick onset of action and they are long acting. So onset of action is slow except formoterol, which has rapid onset action. Now, due to formoterol having quick onset of action and being long acting, it can be used for both purposes, for prophylaxis as well as for quick relief of asthma. So একটা patient যদি আমি long acting formoterol রাখি, the patient can be used for prolonged therapy as a prophylaxis, but as and when required it can be again given because it has got quick onset of action like that of short acting beta 2 agonist. So due to rapid onset of action and being long acting, formoterol with inhalational corticosteroids can be taken for both the purpose, to control and to relieve asthma. They do not treat underlying chronic inflammation. Bronchodilator, beta 2 agonists, basically they cause bronchodilation. They have got lesser role as an anti-inflammatory. So they do not treat underlying chronic asthma chronic inflammation in asthma and may increase the risk of exacerbation of life-threatening asthma when used alone for long period. So তাই জন্য they should always be combined with inhalational corticosteroids which have got anti-inflammatory effect. So they should never be used alone but in combination with inhalational corticosteroids as fixed dose combination. When asthma is not controlled by low dose inhalational corticosteroids, then addition of LABA, that is long acting beta 2 agonist, is more effective than increasing the dose of inhalational corticosteroids. একটা পেশেন্টের মাইল্ড অ্যাসমা নিয়ে এসছে যেখানে ড্রাগ অফ চয়েস রয়েছে ইনহেলেশনাল কর্টিকোস্টেরয়েডস ইন লো ডোজ অর মিডিয়াম ডোজ, কিন্তু যদি দেখা যায় কি এটা দিয়েও কন্ট্রোল হচ্ছে না, তাহলে কিন্তু ইটস বেটার টু অ্যাড লং অ্যাক্টিং বিটা 2 আগনিস্ট রাদার দ্যান টু ইনক্রিজ দ্য ডোজ অফ ICS. They are also used in combination with antimuscarinics. Both salmeterol and formoterol, they inhibit the late phase allergen induced asthma which occur when bronchodilating effect of short acting agent is over. Now coming to the next group of drug, methylxanthines, that include theophylline. So these are basically plant products. Mainly three agents are there: theophylline, caffeine, theobromine. Now theobromine has got lesser effect, has got very weak action, so they have got no role in therapeutics. So we are going with theophylline and caffeine. Now sources of methylxanthines, that include Tinea sinensis from the tea leaves. They have got mainly caffeine and a small amount of theophylline and theobromine. Next is Theobroma cocoa, contained in cocoa and chocolates. Theobromine mainly are there along with some caffeine. Coffee arabica in the coffee seeds contain caffeine, and cola acuminata in the cola drinks containing caffeine. So coming to pharmacological actions, they have got main actions on the central nervous system and on the cardiovascular system. In the central nervous system, they have got stimulant effect, mostly seen with caffeine than with theophylline. Sense of well-being, alertness, allege fatigue, improve performance and increase motor activity. What we basically experience while taking tea and coffee. So higher doses, however, they cause nervousness, restlessness, panic, insomnia, and even with higher dose, tremor, delirium, and convulsion may be seen, which is common with theophylline than with caffeine. Vomiting at high dose. Coming to cardiovascular system, they show positive chronotropic and inotropic effect. Effect on the heart rate is variable. It may cause tachycardia due to cardiac action and bradycardia due to vagal action. However, at higher doses, arrhythmia may be seen. Coming to the blood pressure, again the effect is variable, increased due to cardiac action and vasomotor center, decreased by vagal stimulation and vasodilatation. However, with usual therapeutic dose, a rise in systolic blood pressure and a fall in diastolic blood pressure is seen. Effect on the blood vessels, basically coronary vessels and systemic blood vessels, they show dilatation, and in these intracranial vessels, they show vasoconstriction, particularly with caffeine. So caffeine find a role in treatment of migraine, where the basic pathophysiology is cerebral vasodilatation. Coming to smooth muscles, they get relaxed. The effect is most prominent on the bronchi. Biliary spasm is also relieved. There is negligible effect on the intestine and the urinary tract. Theophylline is more potent here, and effect is much less marked than beta-2 agonist. In the kidney, they may show mild diuresis. The effect is short. Skeletal muscles, particularly caffeine, they enhance the skeletal muscle contractility. Also, the neuromuscular transmission is facilitated by increased acetylcholine release. Again, because of increase in skeletal muscle contractility, diaphragmatic contractility improves, so it shows symptomatic improvement in patients of dyspnea. Stomach, they increase the acid and pepsin secretion, so they act as gastric irritant. Metabolism, they are increasing basal metabolic rate. In the mast cells and inflammatory cells, they decrease the release of inflammatory mediators like beta-2 agonist from the mast cells and other inflammatory cells. Now, mechanism of action of theophylline, as said earlier, they inhibit the phosphodiesterase enzyme. There are 11 subtypes of phosphodiesterase enzymes. It is a non-specific inhibitor. Due to inhibition of PDE4 isoenzyme, it is increasing the cyclic GAMP level in the bronchial smooth muscles, causing bronchodilation. And second mechanism is adenosine antagonism. Adenosine, basically they are contracting bronchial smooth muscles. Smooth muscles, তার মধ্যে bronchial smooth muscles, they are dilating cerebral blood vessels, they are depressing the cardiac pacemaker and inhibiting gastric secretion. Methylxanthines, by antagonizing the adenosine, what they are showing? They are showing bronchodilation, they are constricting cranial blood vessels, they are increasing the cardiac pacemaker activity and increasing the gastric acid secretion. So opposite effect is seen. Deacetylation of histone, basically theophylline, they are activating histone deacetylase 2 enzyme, and thus they are causing deacetylation of histone, thus they are inhibiting inflammatory gene transcription inhibition. So facilitating anti-inflammatory effect of corticosteroids. Finally, they are inhibiting the release of calcium from the intracellular stores. Now, pharmacokinetics, they are well absorbed orally, 50% plasma protein bound, distributed to all tissues, extensively metabolized in liver, particularly by CYP1A2 isoenzyme, eliminated 10% unchanged in urine. They show pronounced inter-individual variation. The drug is of low margin of safety and the kinetics changes from first order to zero order on higher dose. So it's one of the drugs showing zero order kinetics of elimination. Adverse effect, narrow margin of safety, headache, nervousness, nausea may be seen, gastric pain due to increased gastric acid secretion, rectal inflammation if used by per rectal route, rapid intravenous injection may cause precordial pain, syncope and sudden death. Interaction, they may interact with CYP1A2 inducers and inhibitors. Again, they enhance the effect of furosemide, sympathomimetics, digitalis, oral anticoagulants and hypoglycemics. They decrease the effect of phenytoin and lithium. Usage of theophylline in the patients of bronchial asthma, in chronic obstructive pulmonary disease, and again apnea in premature infant it may be helpful, and in patients of acute left ventricular failure. So what are the drugs used in bronchial asthma patient? Bronchial asthma পাশালে কি বেসিক্যালি রিসেপ্টর থাকে সিম্প্যাথোমাইমেটিক? জোরে বলো। হ্যাঁ, beta 2 receptor. What does it cause? Bronchoconstriction or bronchodilation? Bronchodilation. So beta 2 agonist is the mainstay of therapy as a bronchodilator, right? Beta 2 agonist মধ্যে কি আছে? Short acting আছে, long acting আছে. Short acting কি আছে? Salbutamol, terbutaline is a very commonly used drug clinical setting. Salbutamol also called albuterol. Salbutamol, levosalbutamol and terbutaline. Long acting কি আছে? খুব commonly পফে আমরা ইউজ করি এমডিআই হিসাবে formoterol, salmeterol. Formoterol is quick acting, long acting. Salmeterol is basically quick onset of action is it takes longer time and longer acting. Okay, then comes methylxanthines which we discussed right now, that include theophylline, caffeine. আর কি আছে next? Next কি আছে group of drug? Anticholinergics. কেন M3 receptor থাকে bronchial smooth muscle. তো M3 receptor কি করে? Bronchoconstriction করে. Now if you use M3 antagonist or anticholinergics, so that may be helpful, which includes short acting, again long acting. Short acting কি আছে? Ipratropium bromide. Long acting tiotropium bromide, commonly used these are. আর কি আছে next group of drug? Mast cell যে released through inflammatory mediators সেটাকে ইনহিবিট করে. Mast cell stabilizers like sodium chromoglycate. আর কি আছে? আর কোন ড্রাগ ইউজ করা যেতে পারে? Antihistaminic has got no role. Next, আর কি আছে? Leukotriene receptor antagonist. বললাম কি leukotriene is one of the major mediator in bronchial asthma, like montelukast, jafelukast. আর কি আছে? Steroids রয়েছে, ঠিক আছে, that decrease the inflammation, particularly by inhalation route they are preferred. They can be used orally and parenterally in selected conditions. আর কি আছে? IgE antagonist, omalizumab. তাই তো, ড্রাগসের নামগুলো মনে রাখতে হবে। বিটা 2 অ্যাগনিস্ট এটা আসতে পারে, এটা জানতে হবে। মেকানিজম অফ অ্যাকশন চারটে আছে, ঠিক আছে। মেথাইলজ্যান্থিনস আছে, এটা পড়তে হবে। হ্যাঁ, coming to anticholinergics, is a quaternary ammonium compound They are less effective bronchodilator. M3 receptor, they are GQ protein coupled receptors. They act via IP3-DAG pathway, causing M3 receptor antagonist causing bronchodilation. They primarily acts on the larger airways. The larger airways has got more cholinergic receptor, and the smaller airways downside they have got more sympathomimetic receptor beta 2. Okay, so they are more primarily act on larger airways. Ipratropium bromide is short acting 4 to 6 hours. Tiotropium bromide longer acting 24 hours. They have got minimal anticholinergic side effects on inhalational route because of less systemic absorption, but that can be seen. Bronchodilators of choice in COPD patient. It's not of choice in bronchial asthma patient. Anticholinergic are the drug of choice in COPD patient because they are the main reversible component of bronchospasm is basically cholinergic tone. Because cholinergic tone is high in a patient of COPD, and reflex cholinergic tone appears to be the major reversible component of airway obstruction in COPD. Again, in bronchial asthma, the major reversible factor is inflammation. So, inhalational corticosteroids are the drug of choice. Slower response than inhaled beta 2 agonist, regular prophylactic use than for quick relief. It can be combined with beta 2 agonist. Inhaled ipratropium bromide produces more marked and longer lasting bronchodilation when combined with beta 2 agonist. Nebulized ipratropium with salbutamol employed in refractory asthma. However, we should also know that because of anticholinergic side effects, LAMA may produce urine retention. So, it should be cautiously used in patients of benign hyperplasia of prostate. Corticosteroids, if not a bronchodilator, they inhibit inflammatory cytokine production and eosinophilic lymphocytic infiltrate of lung. They are also reducing the bronchial hyperreactivity, mucosal edema, and suppress the inflammatory response. They are also causing upregulation of the beta 2 receptors in lung cells and leukocytes. So, long-term use of beta 2 agonist causing desensitization will be lesser if used along with corticosteroids. More sustained and complete symptomatic relief than bronchodilators or other drugs. ICS, that is inhalational corticosteroids, can control asthma avoiding major side effects, and they can be combined with short acting or long acting beta 2 agonists as a first choice for chronic asthma. Coming to systemic corticosteroids like prednisolone, prednisone, they are used in severe chronic asthma, not controlled with bronchodilator and inhalational corticosteroid alone, or when there are frequent recurrences of increasing severity. They can be used in status asthmaticus, not responding to intensive bronchodilator therapy. In COPD patient, a short course of systemic corticosteroids can be used to decrease the days of hospitalization, and corticosteroids with short half-life and for a brief period possible as much is preferred, so that the side effect of long-term corticosteroid can be minimized. Inhalational corticosteroid, they have got minimal side effect, most suitable for the long-term treatment of asthma, not considered necessary for mild and episodic asthma, but they are indicated in persistent asthma. Airway inflammation in COPD are not responsive to the corticosteroids. Only high dose ICS is beneficial in advanced COPD with frequent exacerbations. In therapeutic dose, side effects like dryness of the mouth, hoarseness of voice, oral candidiasis can be seen, but that can be minimized with the oral rinsing after taking the puffs and via the use of spacer. So, these are the common side effects with inhalation corticosteroids. Cyclophosphamide is a novel inhalational corticosteroid. How? Because they have better topical is to systemic activity ratio. Basically, it's a prodrug that is cleaved down by esterase enzyme in the bronchial epithelium to the active form. Now again, this drug is highly plasma protein bound, as it's a prodrug activated by bronchial epithelial enzyme. Oral absorption is minimal, so they are used by inhalational route. In the inhalational route, by cleaving down in the bronchial epithelium, they are acting at the site of action from where it is given. Again, being highly plasma protein bound, the tissue distribution is very low, so lesser systemic toxicity. Carries minimum risk of systemic toxicity. Budesonide and fluticasone, they have higher affinity for glucocorticoid receptor. Inhaled steroids are safe in pregnancy. Leukotriene antagonists. Leukotrienes are the powerful mediators of inflammation. As said earlier, drugs cause leukocyte recruitment, stimulate bronchoconstriction and increases the capillary permeability. They are also increasing mucus secretion and decreasing the mucociliary clearance. Now montelukast and gefilukast, they are cystinyl leukotriene 1 receptor antagonists, competitive. They cause bronchodilation. They are reducing the sputum eosinophil count and suppressing the bronchial inflammation and hyperreactivity. Episodes of asthma exacerbations are reduced. They are not effective in the acute attack of asthma. They are used as a prophylactic therapy in mild to moderate asthma. They are effective in aspirin-induced asthma, in exercise-induced asthma, but they are of no value in COPD patient. Well absorbed orally, highly plasma protein bound, metabolized by CYP2C9, half-life of montelukast 3 to 6 hours. Gefilukast is a longer acting version, 8 to 12 hours. Abdominal pain, rashes and headache may be seen, and rare side effect eosinophilia and neuropathy, and the patient may end up with Churg-Strauss syndrome even. Xylitol is a 5-lipoxygenase inhibitor, and thus they are blocking the synthesis of leukotriene C4, D4 and B4. They are potential to prevent all leukotriene induced responses, including exacerbation by activation of cystinyl leukotriene 1 receptor. Clinical efficacy similar to montelukast. Hepatotoxic potential is there. Coming to mast cell stabilizers, is a synthetic chromone derivative. They inhibit the degranulation of mast cells as well as other inflammatory cells. Effect possibly involve delayed chloride channel in the membrane of these cells. এই যে inflammatory cells রয়েছে তার মধ্যে delayed chloride channel থাকে. Inactivation of the delayed chloride channel causes inhibition of degranulation of mast cells. Long-term treatment decrease cellular inflammatory response. Bronchial hyperreactivity is also decreased to some extent. Allergen, cold air, irritant and exercise-induced bronchospasm may be decreased. They are ineffective in the acute attack. They are used as prophylactic therapy. Administered as an aerosol, systemic toxicity is minimal and is used in bronchial asthma, allergic rhinitis, allergic conjunctivitis, bronchospasm, throat irritation and cough can be seen in some. Ketotifen has got H1 antihistaminic action as well as chromoglycate-like action. Stimulation of immunogenic and inflammatory cells and mediator release reduced. Is again not a bronchodilator like that of sodium chromoglycate. It is infrequently used now. May be tried in some patients with multiple allergic disorders. Well tolerated. Omalizumab basically is a IgE antagonist. It is a humanized monoclonal antibody against IgE administered subcutaneously. Very expensive. It is found to reduce exacerbations and steroid requirement in severe acute asthma. No benefit in allergy group, as it only antagonizes IgE, which is related to allergic reaction. So these are not helpful in non-allergic asthma. Indicated in resistant asthma with positive skin test with raised IgE level requiring frequent hospitalizations. Being tried in some other allergic conditions as well. It is very expensive.